Good morning. My name's Diane Watson. I'm the manager of clinical information systems at St. Louis Children's Hospital. Welcome. We are in the home stretch. And with that note, I did learn at dinner last night, just a little sidebar, that the Philadelphia Phillies' rivalry are the Mets, just like the Cardinals and the Cubs. So with respect to our distinguished guest this evening, this morning, I would like to give a little shout out to our Mets partners today in beating the Cubs last night. So thank you. Okay. All right. Go Royals. Okay. So I have the distinguished honor of introducing Dr. Bryan Wolf, who is a native of Los Angeles, California, and due to the fact that I do not speak French, I will just share with you that he got his Master's in Science in Pharmacology, his physician training, and his PhD in Nutrition and Endocrinology in Paris, France. He also did a postgraduate stint here at Washington University back in 1984 to 1990 with biochemistry, lab medicine, and chemistry departments. Since 1990, he has served many roles at the University of Pennsylvania and Children's Hospital in Philadelphia. Primarily, between 2008 and 2015, he was the CIO and Senior VP for CHOP during their EPIC implementation. His current responsibilities at Children's Hospital is the chair of the recently developed Department of Biomedical and Health Informatics. In addition, he is the Chief Scientific Officer and Executive Vice President and the Director of Research Institute. My only question is, how big is his badge? With that, in addition, he has been the principal investigator of 24 different grants, of which focused on a disease that is very dear to my heart, diabetes. So I thank you for your work. And with that, it's my great honor to introduce Dr. Bryan Wolf.
Thank you so much for that introduction. It is a pleasure being here. As you mentioned, I trained here from 84 to 1990. My daughter was born here. And I'm pretty sure that this was the site of my pediatrician's office. I'm pretty sure of that, and maybe my internist, but I cannot recognize South Euclid. It's just remarkable. So I have no financial disclosures, no conflicts. And I'm here today to talk about informatics at CHOP. And so I'm going to give you a bit of a background on why we've created this department. DBHI is the acronym, which I'll come back to. Why we wanted to have an informatics department based at CHOP. I'll talk a bit about some of the themes, the challenges that we've had through numerous strategic planning. I seem to be doing strategic planning in different roles non-stop these days, and then talk a bit about how we're structured. So this is the mission for CHOP, and it's the typical tripartite mission of care, research, and education aimed at children. And CHOP is located on the campus of the University of Pennsylvania. So similar to the situation here, all the faculty are actually paid through the University of Pennsylvania's School of Medicine. But the difference stops probably, and this is for Dr. Schwartz, in the sense that we're actually financially completely independent, administratively, financially. So we're sort of freestanding hospital on the campus. And of course, we have all the issues you face in terms of working with the university, the School of Medicine, what we call Penn Medicine, which is the adult hospital, so the equivalent of Barnes and Jewish, Christiana. On the adult side, for us, it's called the HUP, Hospital of the University of Pennsylvania. And we do have different systems. We'll all be on EPIC at some point, but we're not yet. So that's sort of the background of where CHOP is located. We're a pretty large children's hospital, about 530 beds, but we mainly have a very large outpatient network of primary care and specialty care. So we sort of dominate what's called the Delaware Valley, from probably Delaware through southern New Jersey. We have about 1.4 million outpatient visits, about 12,000 employees, The number of practitioners and research investigators are shown here. And we've been in a constant building phase over the last 15 years of just expansion. And we also have tried to move into the national type of affiliations. We had a stint with UT San Antonio, which led nowhere, but we were going to build a children's hospital in UT San Antonio. That did not happen, and we're obviously looking at expansion in the region and potentially other things in the Northeast. And it's all part of the same goal of how does a freestanding children's hospital survive in the context of changes ongoing in healthcare. So we had until recently, a very progressive CEO, Steve Altschuler. He was the CEO from 2001 through 2015 when he just retired, former chair of pediatrics at CHOP and Penn. And he's the one who got me over from the adult side, because I used to work at the University of Pennsylvania School of Medicine. He brought me over as chair of pathology 15 years ago. And he's a sort of visionary, and he's always 5 to 10 years ahead of his management team and his executive team. So in 2003 or 4, he actually had this vision of having a common electronic health information platform for everyone at CHOP throughout the system. It took us 10 years to implement his vision. I think he thought it would take 2 years, but it's here we are. That certainly was his probably his legacy now. And then the other point that he pushed was to use that information to transform pediatric healthcare. So these are quotes from his talks, and this is concepts that he evolved in 2003 through 2005, and then we've tried to follow. So we had the pleasure of doing an Epic implementation, and I became the CIO in 2008, and my goal was to get the IT groups to work with the rest of the hospital. The IT group was quite siloed, and I was brought in to get that alignment. It was very, very clearly stated. In 2008, we were just starting the Epic implementation. It wasn't going well, I would say. This is my lab medicine background here, which is where I trained. This is from my WashU training. And so our implementation was not going well. In fact, it was going south, and so we had to take some measures to get it back on track, and I'll explain a bit more about that. And that little number that you see dangling there, that's our total cost of ownership of Epic from 2001 through 2015. That's one of the first things I did, is calculate how much it actually cost to put in Epic, and of course to maintain it. So you could build a very nice building for that price, probably 8 to 10 stories, maybe even larger. And so it's an expensive endeavor as you're putting this in. And of course, the Board of Trustees asks me all the time, what's the return on investment? And I can't answer those types of questions in a business sense. I can talk about, at least BMOL can talk about safety and quality, but it's very hard to show the true return on investment, except that you can't use paper nowadays, and that's really the argument. So how did we go about this? Well, we took our time. So I came to CHOP in 2001. I was put as one of the chairs on one of the oversight committees. This was to put out Epic in primary care. We started in 2001. We had hurdles, and by 2003 we figured out how to do this in a cookie-cutter fashion, which took us almost 3 years, as you see. And then in 2006 we started working with the practices, the specialists. There was a bit of tension, I would say, between the primary care docs who had spent 6 years figuring out how to do this well, and the university-based division chiefs, all my good friends, who had different opinions on this. And so I was put in as in 2006 as the executive sponsor for specialty care, and we did. Why we started with surgery, I will never know, but we started with surgery and allergy and got them to start using that. And then in 2008, when I became CIO, we started doing the rollout of Epic inpatient. In the meantime, in 2007, we put in the patient access revenue cycle piece, which was done in 2007. it wasn't viewed as a great success. Epic told us to our face that it was a mediocre installation. So that was sort of their grading of us. But obviously it was important to have the scheduling piece in place. And then, as you can see, from 2008 onwards, we started doing all the clinical systems. And by then, we were much more experienced in knowing what to do and what to avoid. And apart from getting a really strong outside project director who got the group lined up, we got Bimal Desai and his nursing counterpart. And that was probably the most important success factor, was having the clinicians being part of the build. And he showed you the numbers. I mean, we funded a lot of clinicians, physicians, nurses, and it paid off. And I can't emphasize this enough. It's probably the main reason why we've had very smooth and successful implementation, which has been our history since 2008, is to have basically as painless as possible in implementations. And when I discussed this with the chair of the board of trustees, who was the former CIO from Vanguard, the mutual funds, he did the similar things, but in his world, in finance, it's dealing with the traders. So we deal with the division chiefs. For them, it's dealing with the high-end traders. It's the same type of personalities and challenges, apparently. And so that's so he also had those people being involved in the implementation, which is what we did. So we were planning to go live on 10-10-10. It was a great day. We had T-shirts. We had posters. I mean, it was just perfect. We had everything was designed for 10-10-10. It resonated. And then, unfortunately, in May of 2010, we realized that we would never make 10-10-10 without killing a few patients, which was completely unacceptable. We had 2,000 defects in our build, mainly on the pharmacy side. And so I went to the board, the CEO, and I said, I'm not doing this. I was tenured, so I didn't really care about the consequences. But I said, this is the right thing to do. And we basically got the board to agree to a 6 months delay. And we went live in a less catchy date, but it was January 21st of 2011. And we had a very smooth implementation of most of the inpatient systems. Then in 2012, we did clinical documentation, and that's when we really got the benefits. So up to 2012, we still had complaints. We had adoption issues. People were concerned about the number of clicks, depending on the specialties. And clinical documentation really provided a true benefit to the users. And so at that point, people were saying, oh, this is great. I can access the patient's note from home, et cetera, et cetera. And that was sort of the turning point when basically people accepted the Epic system in our institution, recognizing that we still did a lot of optimization. So in those $400 million, we spent maybe a quarter or a fifth of that on things designed to optimize the experience for the clinicians. And that's an ongoing effort to meet the needs of the practices. Then we did the ORs with Uptime and then Epic Anesthesia in January. And then, of course, eHealth, which is a key aspect of allowing us to interact with our other colleagues on other campuses, including the adult side, which is also going to Epic. So that was the basic background around Epic. So why create a new department? Well, what we figured out in 2013, 2014 is that we had spent all this money into Epic, so we finally had our integrated electronic health system. We had an enormous amount of clinical, administrative, financial data on our patients. And at the same time, we had built, on the IT side, we had built a CHOP data warehouse during that same period, which had all that data pulling from different sources, and I'll show you a slide a bit later. And also, on the research side, there had been established a Center for Biomedical Informatics led by Pete White, who's now moved to Cincinnati. But they had worked really on the research side around genomic research, data reporting, education, and things around the EHR intervention and scientific computing, et cetera. So a strong group there, but they were really based on the research side. Pathology also created a new division of genomic diagnostic and realized very suddenly that they had enormous bioinformatics needs for the clinical side. So all these things came together with a number of surveys that we did, and you can see that in 2011 on the left there, we did a survey of the faculty, around bioinformatics, and it was very critical. It showed all the different gaps. It needs to be more robust. And we use the term bioinformatics, but people probably were thinking sometimes medical informatics, perhaps translational, and or bioinformatics. Everyone felt that there was issues accessing the data. Data governance is unclear. And I'm sorry to say that's still unclear these days, but we've made some progress. There was a need for information integration, and it wasn't clear how you could get these things funded. So then we did another retreat in 2014. This was to create this new department, and people felt that basically in 3 years nothing had changed. So it validated that even though we had put in all this effort, we didn't have an informatics program that met the needs of some of our investigators. Outside of the needs on the clinical side, which BMAL was leading, where there it was very defined and focused on what needed to happen. So the CEO got involved, Steve Altschuler, and he agreed to create a new academic department, which was to pull together all the different initiatives in informatics and analytics on the IT side, by basically leveraging what we had invested in EPIC and CBMI, funding an informatics fellowship, and then the package included 10 new faculty positions in informatics at CHOP. And then there were dollars for incremental resources around data scientists and a scientific computing group that was based on the research side. And so that was put in place in fiscal year 15. We did a very large strategic planning process. We had 4 retreats to try and understand what the stakeholders needed. We got a vision, which is shown here, which is once again a typical tripartite vision, but centered around informatics and around children. We felt that was very important for us to distinguish ourselves as a CHOP-based informatics. And we called the department Biomedical and Health Informatics. We spent months on that. But to acknowledge, I'm looking at my friends here, but to acknowledge the spectrum that this department had to be completely inclusive from the basic science, pure bioinformatics, all the way to the clinical informatics side. And I was passionate about that. I felt that was really important. And as you can see, our mission statement, which is shown here, has those 3 components, and it's about solving challenging problems. And you'll notice we talk about the interpretation of biomedical, genomic, and clinical data. Even though some of it is a bit redundant, the different stakeholders wanted to be sure that their data was represented in that first mission statement. But it's all about solving challenging problems. That's what makes us tick. The second piece is about advancing child health through pediatric health IT. And so that's sort of what you saw from BMAL falls under that category and then goes back and forth between the first one. And the third one is about education. It's about creating a continuous learning environment. We started out thinking that we just needed to focus on the fellowship, but we realized there was a need to train people in informatics more broadly and also in bioinformatics. Our PIs on the basic science side were clamoring for help on the bioinformatics side. So that's how we organized the mission of this department. And then we tried to understand what are the themes that came out of this. I was the chair of the School of Medicine Committee on Appointments and Promotion for 6 years on the Penn side, so I'm very familiar with promotion standards and publications. And obviously when you're setting up an academic department, you want to make sure that you address those things. We had a lot of themes, and the first 2 are sort of not at all surprising. The first one was around data and analytics. And the issues are, because they still persist, is how do you get to this data? How do you obtain the data? And what's the data governance around that? But we felt that to be successful, this department had to address data and analytic, including data governance and data security, which is very high on our minds here. The second theme was around technology needs. And so, of course, coming from the IT side, where part of my life was around moving data centers. We built a brand new data center to accommodate the EPIC implementation, plus we had a second one has a hot backup. So lots of issues around storage, bandwidth, high-performance computing, and how do the hospital-based IS groups support these types of initiatives. The answers are actually quite easy, but it's all about money. So it's very, I mean, there's no limits in terms of storage and bandwidth as long as you can pay for it and figure out how to pay for it. But we can get petabytes servers very, very easily. And so, but it requires an alignment on the hospital IT side, which controls all the data centers and the networking to get that investment. We were also concerned about faculty development and recruitment. We have 4 different faculty tracks on the university side. People who get appointed have to get promoted on the University of Pennsylvania standards. The standards are demanding. They focus on publications, grants if you're on tenure, etc. So we had to address how would we deal with the different types of faculty being appointed in DBHI. And including where would they live as their home department on the university side, which could be pediatrics, which it is in many cases, it could be pathology, but we're also doing appointments in genetics and in biostatistics and epidemiology because there's a new Institute of Biomedical Informatics on the Penn side that has a division of informatics, and so we can appoint PhD-type scientists in that division. And I don't really care, to be honest. For me, I've been on the campus long enough that what counts is having faculty who are successful, and where they live in terms of a faculty, in terms of a department, is less important as long as there's an umbrella around informatics. There was a lot of questions about the focus of the new department, and specifically the relationship with Penn. So Penn founded this Institute for Biomedical Informatics with Jason Moore as the founding director in April. He also has 10 faculty positions, and we're doing our searches together, actually. So the campus has about 20 faculty positions to recruit in informatics, and we've decided that we're not going to compete with each other. We're going to appoint, and we're going to do these searches together. And so I think you'll see more and more positive interactions with the Penn IBI is the name of the group. Education was felt to be key, and I'll come back to that, but we wanted to expand our fellowship in medical informatics, and that's funded through the department. And then there's a whole list of educational opportunities similar to what you're doing here that we feel are important to teach, to talk about informatics on campus. And then finally, the hardest theme is around integration, which is how do you get all these different groups that are inherently siloed? Some are like a basic scientist will care about his or her research, and they're siloed, but they need bioinformatics. They may need phenotypical data from the EHR if they're moving into something more translational, but they don't know who to go to. They don't know that there's a Charlie Bailey or Mike Padula because they live in different worlds. And so the challenge, and it's a real challenge for which sorry to say I don't have the best solution yet, is how do you get these groups to work together in an integrated fashion? Even though we're all on the same campus, it's still getting the faculty to interact. So what we decided to do at the retreat is we decided to create vignettes. And the goal of creating vignettes was to say, okay, where should we be 5 to 10 years from now? And we thought that having a narrative around vignettes would help us figure out what were the steps to get there. So we had actually 22, narrowed it down to 14, all really good. And I'm only going to show 2 of them because this would take another hour to go through the 12 other ones. But to give you an idea of the vignettes, here's one which actually is really important, which is that informatics supports large collaborative research projects. And it could be around safety. It could be around personalized precision medicine. It could be around population health. And of course, what Charlie Bailey described with PeasNet is a good example of that, where we're starting to do that. But this was clearly a vignette that resonated with a lot of the faculty in terms of this is what we need to aim for 5 to 10 years from now. And as you heard in the presentations this morning, we're starting to address this, although we certainly didn't talk about population health in a more epidemiological fashion. And then this one, which I really like, which is you link all patient clinical and research data. Simple concept. We're not there yet. We've linked a lot of data, but I can tell you we don't have any genomics data in our main data warehouse. We have them in separate databases, but not all linked together. And at some point, if you can really get to that And maybe we won't do it at CHOP, maybe we'll do it through PedsNet, because this is something the PedsNet board is interested in discussing, is should there be an omics component to PedsNet, and maybe that's the better way to do it. But we felt this was a very important vignette, and that's something that we're really striving for. So we also asked for feedback from our faculty stakeholders, all 60 of them who attended the retreat, because we were trying to get clarity on directions, on where to go, what to do. So we asked about the top 3 areas for faculty recruitment, and I'm happy to say we got actually good alignment. So our group felt that we need a senior clinical informatician. I don't know how I'm going to find someone like that with a pediatrics background, but that's something we would like to have a more senior faculty, full professor type, who's focused on clinical informatics with a national reputation, who can help our more junior faculty as they progress in their careers. And that's something that we just don't have neither at Penn nor at CHOP. So that's something we feel is an important recruit. We're going to be recruiting in genomics and bioinformatics, and so that's started. We've actually already recruited one tenured associate professor in bioinformatics, and we're negotiating with a full professor, statistical geneticist, so a very specific need for the campus that we hope shall be coming. We believe we need to have data scientist faculty positions, so I'll show you we have data scientists in the department, and at some point we'd like to transition them to faculty positions, but we're a bit worried about when the clock for promotion starts. The Penn system is up or out after 6 or 9 years, depending on the track. But those people are very hard to find. And then other ideas were computer scientists, although we probably would do a joint recruitment with the Penn Department of Computer Science. And then there's also an interest in bringing someone who has industry experience into the department. But right now we're focusing on the top 3 areas for recruitment. And then we asked, well, where should the funding come from? What are the top areas, the most fundable? And unfortunately, as you can see, we got 50 different answers. And I think that just reflects the variety of the background and disciplines that most of the faculty who do informatics come in. And so we don't really have a good answer on where would you fund informatics research in the next five years. And as you can see, it covers the whole gamut of what the department actually does. So that was our retreat, which led to the creation of the department, which started in July of 2014. So we're about a year and a few months old. And so we had some very specific goals, which I'll go through quickly. We created an executive committee. We haven't yet put in an external scientific advisory committee, but I think that's going to be important as the informatics department grows. We hired a new director of bioinformatics who also joined the faculty, and that's to oversee the bioinformatics group, and I'll show you, I have a slide on that. We hired for a scientific computing group, actually someone who used to be at WashU and then Monsanto, and that's to we felt it was important to have someone on the departmental side who could translate with research IT and hospital IT the needs of the scientists. And it's been, because our computing needs tend to be high-end compared to most computing needs that the research IT groups would support. And this person has been actually outstanding and actually came from him. We've expanded the fellowship program to 2 fellows per year, and it's ACGME accredited now. And then we have these open faculty recruitments I mentioned. In terms of the relationship with Penn, so we're working very closely with Jason Moore. He came from Dartmouth, as founding this new Institute of Biomedical Informatics, and we're doing all our recruitments together. And once again, if someone's more pediatric focused, they would probably be based or funded through DBHI. Otherwise, they'd be funded through the IBI side. We still haven't really done much on data access and use, and that's still one of the biggest complaints for people, which is how do you get data? And there's ways, but you have to know. Or you have to know people, but there's no self-service easy way yet to get to data, although we have ideas on that. And then we've used the vignettes to create very detailed roadmaps of what needs to happen, and starting with things like the technology piece to move forward. So that's the sort of background of what led to the creation of the Department of Bioinformatics, DBHI. And then I just want to talk about the non-faculty groups that are sort of the core resources available in the department and which are available to the faculty who are part of the department. So we have a group focused on bioinformatics and genome analysis led by Deanne Taylor. It's about 15 FTEs, all PhDs. And what we do with that group is we typically assign them into the labs of PIs as long as they have some funding. And our model is that you have to spend at least 50% of the time as a bioinformatician in the wet bench lab. Otherwise, it's not going to work well. So the 10% use of a bioinformatic time here and there is just not a good model. And so we've pushed for 50%, and that's worked quite well in the sense that the person becomes part of the lab and gets papers, etc., grants, etc. But at the same time, we provide the oversight and the home from a community perspective with the rest of the bioinformatics group. We've also started managing postdocs and scientists for other PIs, so we found that a lot of PIs, like my colleagues who had similar backgrounds, they just don't know how to hire a bioinformatician. They don't know what to look for. They don't know even how to manage the progress because it's such a different discipline. And so we've taken on, as a pilot, hiring postdocs. They pay for them, but we sort of do the hire, and then we monitor their progress. And that seems to be very, very successful. And then you can see some of the functions that the group can provide. The other group is led by Bob Grunmeyer, who's a pediatrician. It's around data reporting and management. And so this is where the group serves as the electronic honest broker between the PIs who want to use data and then the data warehouse. And so this is called a clinical reporting unit. It's very largely used. It's focused on research. And the group is very successful. It's just that we probably would need 15 people instead of 7 to provide the level to answer all the demand that's available. But they have the very specific expertise in putting the data either out of the warehouse or out of Clarity. And obviously works closely with PeasNet. The people on this team support PeasNet. And this shows a data warehouse. So we built the CHOP data warehouse starting in 2008 after a few attempts of other warehouses that weren't too successful. And this is run out of IT, out of the analytics group that's in IT. And we basically have all of the EPIC data, but we also have a lot of outside data, registry data. It's a very extensive warehouse, but it doesn't have the research omics type of data, and that's something that we're considering. But for most people who have research questions, accessing this warehouse is usually sufficient for at least for an initial analysis. And of course, this is what's used on the operations side for the hospital, and all of financial stuff comes out of this data warehouse. And we've struggled with data governance. I know this was a question you wanted me to address, but we've tried for 15 years to put in place data governance. We're on our third or fourth iteration. The main conclusion is we decided that data governance should not be owned by IT or finance. So the CFO and I, when I was CIO, we got together. We understand that if we did that, because we had the expertise, but we would fail. And so the data governance is now owned by Ron Karen, who's the VP of Quality. And we think that's a better model. But we're just starting to get the buy-in. And there's always going to be tension between the financial side and the clinical side. And so having a process to work through those is pretty essential. But we are not there yet. We have a plan, but we haven't executed on that one. And then we have a group of Translational Informatics led by Jeff Pennington with 17 people. And these are software coders, but with an interest around biological questions. This is the fun group that gets to do all the fun stuff, the people who like to tinker and pull together and create new software. And this has been incredibly useful in research projects because we've been able to create a software that's very specific to answer those to solve those challenging problems that we described. And there's just more information in terms of how they do and how they interact with people like Bimal and Charlie and Mike Padula here. And then my last slide is around education. It's led by Tony Liberti. So obviously the Clinical Informatics Fellowship, we felt that was very important, and that's funded completely through the department, since the PEDS doesn't want to fund this, the hospital doesn't want to fund it, but we felt that if we're going to establish an academic department, we need to have a fellowship, 2-year fellowship, 2 fellows a year, and we hope that that's also a pipeline for future faculty. We have about 13 board-certified faculty in clinical informatics right now. Hopefully 3 more will pass their boards this month. But that's where our strengths are, is on the clinical informatics piece. And we think this is an incredible opportunity for people who are interested in informatics, because now that there's a board, there's going to be an enormous demand. We've seen just with our EPIC implementation, it just opened up an enormous amount of opportunities for faculty. And then we have a number of seminar series and symposium, and tomorrow is our regional healthcare informatics symposium, which is where most of our faculty and staff go and present. So that's sort of how we've organized the DBHI. We're very young. We're starting fresh. It's fun to start fresh. But I think this is an exciting time. If you can link informatics with what's happening with your EPIC implementation, you're going to be sitting on an enormous amount of data, and you're going to need the informatics faculty to analyze and make sense of the data and to do discovery. And that's where the fun is. Thank you.
Questions for Dr. Wolf?
Yes, I have a question. When you are going to be getting access to your individual users, and they are doing a research project, and they have an interpretation, let's say, of how medications are administered, and they think it's coming from this particular data, but if clinicians or whoever's actually configuring the EPIC system know that it's coming from another part, how do you plan on preventing the misinterpretation of data so that the research will not reflect falsely on that?
Sure. So that's the next outstanding question. So typically, if it's in the data warehouse, there's a data model and there's usually agreement on what makes it into the data warehouse. So if people are pulling the data from the CHOP data warehouse, then they'll have less issues. But the real answer is we recommend that they speak to the clinical informatics group. And that concept of doing a consultation that Bimal described, that's exactly where you'd go in, so that you don't make those mistakes. For simple slice and dice type of things, that there's probably some self-serve opportunity, but at some point, you're going to need an informatician to help you understand the source of data.
Were you able to make your data available prior to EPIC as well, so from SCM and EPIC?
Yes, we have. So it depends on which sets of data, but some go back further. The lab systems go back. We've kept all our legacy systems are in there. So we were on SCM for 5 or 6 years. SCM was just a temporary solution for us on our journey, a 9 million temporary solution, but it's a temporary nevertheless. So all that data is there. And so whenever we decommission a system, we put it in the data warehouse. And that's been our strategy. We did that with the anesthesia system. They went from CompuRecord to Epic Anesthesia. Same thing, we moved the data. Other question?
The slide you had there with the data warehouse. Previous to the data warehouse, you had multiple sources of truth for the data. How did you manage to allow access to that, and where does that data reside in terms of...
So before the data... So before the data warehouse, there was another data warehouse. What was it called? I forget. It was a disaster. It was completely inaccurate. All the lab data in there was wrong. Anyhow, so that was one problem. So people stopped using it when they realized that there were mistakes. And so then the data resided in different groups, and depending on the group's acumen in pulling data from their system, they would pull data. So what would happen is you'd have the hospital finance would pull its data, and we use Lawson. The practices had a different system, and the data wouldn't match, and they would get into big fights over what was important as you were trying to do planning, for example. So that was the before. And so once we went on one system, it made it a bit simpler. But even with that, because we don't have a strong data governance in place, so we still have issues on some of the data elements where there may be disagreement between finance and, let's say, quality. And so then that usually, and we have a mechanism, there's a committee that can help address that, but it's tough work because every group wants to look out for its own issues. And so what finance needs is going to be different than what quality needs, for example. But the good news now is that being on a single platform makes it much easier because you're starting with the same source of truth in principle.
So great. So thank you, Dr. Wolf.